Our last respondent this morning is James W. Lytle, the managing partner at Manat, Phelps & Phelps, in charge of the firm's Albany office. He also oversees the firm's New York State Legislative, Lobbying, and Regulatory Affairs divisions. He represents a broad array of clients before the legislature, the executive branch, and the courts, both within New York State and beyond, generally regarding issues at the intersection of the public and private sectors in heavily regulated industries. The firm's New York governmental practice includes representation of clients in the healthcare, educational, cultural, biomedical, insurance, pharmaceutical, economic development, and other sectors. Mr. Lytle's regulatory and legislative work has involved issues relating to insurance regulation, biomedical research, services and programs for persons with disabilities, procurement and government contracting, human services, the regulation of the professions, and educational issues. Please join me in welcoming James Lytle.
Thank you very much. You'll notice in that overly extensive bio no real reference to my TANF expertise, which is appropriate. I do think I'm the odd man out up here and the apologist for the Medicaid industrial complex. I did get an email from a colleague who's also a card-carrying member of the Medicaid Wonk Society saying, what are these welfare guys doing discussing Medicaid? And there is a sort of view that I think is shared within the healthcare world that, you know, this is something that this is our little fraternity or sorority that, yeah, and just leave us alone. And we won't bother you in terms of the actual success of TANF. The reality of Medicaid reform is that it has been a constant in New York. I suspect, and I should do the research, that sometime around 1966, Governor Rockefeller must have convened the first group assembled to try to figure out a way to deal with this over-bloated program that was running out of control, even in its earliest days. My first day in the governor's office in 1983 was to go to a Medicaid reform group and begin talking about changes that had to be made and talk about personal responsibility. Number one on the list was children are going to pay for their parents' nursing home care, was a recommendation that came out of the budget division, and like many other recommendations seem to come out, which I, as fresh from a legal services background, had I thought the obligation to inform people this is a great idea, except it's entirely illegal under federal law. And I was then persuaded by Pat Bulgaro, the budget director, to leave it in the governor's proposal because he had it on a strong assurance from the Senate Finance Committee that it wasn't going anywhere anyway, and happily presented to me the press release the day that we introduced the bill indicating the Senate was going to have nothing to do with it. So that's personal responsibility in the Medicaid program, I suppose. I think there's always been a level of personal responsibility in the program. I think it continues today, and I don't disagree with the notion that we should examine these issues very carefully, thoughtfully. Certainly no one should feel comfortable that we've got the Medicaid program just right, given the information that you all know about it. But I do disagree with some of the recommendations that Russ has assembled and share, I think, some of David Hansel's concerns about making sure that we do no harm before we move in that direction. There are differences, I think, between Medicaid and TANF. And one of them is that, particularly in the context of the Affordable Care Act, Medicaid is now one piece of what hopefully will be a sort of seamless transition for people, many of whom do go from Medicaid to private health insurance, even under the current arrangements. But we all have received a level of federal support for our health insurance costs, either in the form of tax treatment of health insurance benefits or pure state subsidy through Medicaid. And the notion is that we'll have a health insurance system, not a welfare system, a health insurance system that allows people to seamlessly move from program to program with some level of government support where necessary. You know, essentially healthcare ends up, and access to healthcare ends up being something that we regard more as a right than it's ever been viewed before. Certainly some of the elements in Russ's thoughtful paper, I think, deserve support. He notes the contributions that can be made through things like supportive housing, which is a key component of the MRT waiver request before the CMS at this point, which is asking the Medicaid program to do something which it has not traditionally done, which is to provide support for a significant level of support for housing, which everyone acknowledges is a key element towards improving health care status. As to certain other elements, I think it would be great to have some of these other ideas tested and assessed, maybe preferably in Idaho. I would point that we're a little further down the road in some of these areas than maybe is fully reflected. Cash and counseling programs, for example, may not have been enacted in those terms in New York, and as Russ points out, Governor Spitzer vetoed a proposal to do so. But the reason he vetoed it is because we have had a consumer-directed personal assistance program in New York for some time that's been quite successful, that allows persons with disabilities to engage in contracting for personal care services and fire aides if they're not satisfied with their performance, et cetera, and to undertake that sort of personal autonomy over their health care services. Now, as of just a few weeks ago, these services are now been included within the mainstream Medicaid managed care benefit and within the managed long-term care benefit, and are therefore, I think, becoming likely to become even more widespread. I recall hearing Linda Gibbs describe the New York City Opportunity Initiatives and was very impressed by the fact that Mayor Bloomberg was frankly not only putting the city's imprimatur behind this initiative, but some of his own resources. And it was an impressive experiment that, at least as far as I could understand, did not in fact render the results that had been hoped. In the healthcare arena, the reduction in emergency rooms use was very modest, about 2%. There was an increase in the degree to which people remained insured in the Medicaid program, but about 2 or 3%, but there was a whole host of other reforms taking place at that time to avoid churning in the Medicaid program, to improve the eligibility process in Medicaid that may have had something to do with that result. There is always a worry that, as much as it obviously makes sense to encourage healthy behaviors, that initiative, the encouragement, the positive incentives that might be drawn in that direction, has a tendency to morph into some sort of punishment of individuals whose bad behavior continues. Arthur Kaplan, the medical ethicist, in the context of a debate on this subject, said it's as if Cotton Mather had become our own healthcare czar, and we're punishing sinners as well as trying to promote good healthcare outcomes. There's no question that incentives work in certain respects. Public health experts tell me that the most important thing we did in smoking cessation as a country was to tax the hell out of tobacco, to the point where it becomes increasingly unaffordable for people and has had a significant impact on its availability. The problem of dealing with some of these behaviors, including issues around obesity, addictive behavior, is that they're complex conditions, and complex factors have contributed to them. In some instances, financial incentives are simply neither necessary or sufficient to get to the point of addressing some of these complex conditions. One of the most alarming conversations I've had recently with a pediatric expert in obesity who was explaining to me one of the factors that has been identified by a number of researchers as to explain the association between obesity and African Americans across our state and country, is that it's believed that obesity and the ability to maintain weight was in effect a genetically positive attribute of a slave that was being thrown in the bottom of a boat and ready to go across an ocean's voyage, and the likelihood of survival increased significantly if people metabolized in a particular way. And that to some extent it is that ingrained genetic predisposition to obesity that is at least one contributor to the problem. Issues of addictions are also been identified as potentially having genetic origins, and the worry is that to the extent one is certainly punished for having predispositions in these areas, may not be ethically appropriate. Nevertheless, dealing with the chronic conditions that do account for a very significant part of our Medicaid budget is the right focus. A lot of what is in the Medicaid redesign team efforts is directed in that fashion. New York now leads the country in terms of its emphasis on coordinating care, moving the entire Medicaid program to a coordinated care approach. We have a managed long-term care program that now enrolls close to 70,000 individuals who are now accessing the very expensive and significant care that they require in a coordinated care environment. We have more patient-centered medical homes than any state in the country, moving in the direction of health homes to coordinate other chronic conditions. What Atul Gawande noted in one of his many widely read articles about healthcare in the New Yorker a while ago about what was being done in Camden, New Jersey, in terms of very intensive coordination of chronic care conditions of patients that essentially seem to almost require that the care coordinator move in with a person who is in the midst of trying to deal with a chronic condition to try to make sure that the behavioral issues were being addressed, that compliance with medication was being assured. It is an intensely high-touch involvement that's necessary to deal with many of these conditions, which I don't think are going to be amenable to a financial incentive as the necessary solution. But notwithstanding my worry, that I think is somewhere along the same lines as David's, I certainly welcome the debate, and I think it's important that we continue to examine the ways in which the healthcare system can be improved, and personal responsibility certainly plays a role within that. Thank you very much.